Let's move on to the newly diagnosed AML patients who are unfit for chemotherapy. And I'm going to have Dan start off with this. Dan, you've been a leader from the beginning in the phase 1b studies with hypomethylating agents with venetoclax. Why don't you tell us about the practice-changing abstracts that have been presented at EHA and ASH regarding those venetoclax combinations?
Right. Well, thanks, Harry. I think, most of us who treat AML, have been very excited these past couple of years to see what venetoclax can do for some of these patients. As you said, the patients we're really focusing on here are older patients who, either by reason of age or comorbidities, are not fit for a standard intensive induction chemotherapy option, receiving either venetoclax in combination with either a hypomethylating agent or low-dose cytarabine. So, with respect to the hypomethylating agent, we've had approval now for the last year and a half based on some really phase 2 data, non-comparative study showing very promising response rates and survival. And so we all were anxiously awaiting Courtney DiNardo's presentation just this past weekend at EHA, which was going to finally show us in a randomized setting how venetoclax plus azacitidine did in this population versus azacitidine alone. And as most of us know, who've worked in AML, this is a critical test, a time at which a lot of prior therapies have not been able to sort of surmount this, this challenge in a randomized setting. I think, again, most of us who treat this disease were relieved and very happy to see that the data for the venetoclax arm really performed very consistently with what we have come to expect it to based on the phase 2 data. So, we were not disappointed, at least just specifically looking at the venetoclax patients. A response rate somewhere north of 65%, and a survival on the order of 15 months. Now, the critical thing again was to compare to the azacitidine arm, and we're ready for some sort of twist or something thrown at us, an underperforming or an overperforming arm. But in fact, the patients who received azacitidine performed pretty much how we would have expected them to historically. And in fact, we saw a nice statistically and clinically significant improvement with respect to response and survival. So, I think those of us who've been using this frequently in the last year and a half, based on the approval, are reassured that this is likely the new standard of care in this setting. And then, just a comment quickly, because it was raised, there's also, the question of combining this with low-dose cytarabine, which is a much more commonly used drug in many other places in the country. Similar enthusiastic data around the phase 2. And then we sort of had, based on a press release and some other information, the impression that the study would not be a positive one when compared to low-dose cytarabine alone. Gail is, I believe, the senior author of that study that was just published in Blood. I would encourage people to read it because, when patients were followed for a little bit longer than the original planned analysis, which is, definitely a weakness of the planning of the study, but the reality of it was that when you followed patients out to a 12-month time point, there was in fact a survival benefit. So there's a lot of explanations for why maybe the low-dose cytarabine patients seem to underperform. It is, by definition, it was a tougher patient population. Upwards of a third of those patients were allowed on who had a prior hypomethylating agent for an MDS. Those patients were completely excluded from the azacitidine arm. So there's a couple explanations there, but I think it gives us more options, and for us in the leukemia world, I think there's no way that's not a good thing.
Gail, did you want to chime?
Yeah, I think so. The VIALE-A study, as it's now kind of widely known as, looking at azacitidine plus venetoclax versus azacitidine alone, that's the new standard of care for AML period, full stop. I think it's actually really rough in Europe where they don't have it yet, in other parts of the world where they don't have it yet, because I think that we've seen incredibly higher than usual response rates. I mean, we've been stuck in 28 to 30% response land for older patients with AML for decades, and now that's not true. Those over 60% response rates across cytogenetic groups, across molecular groups are real. They happen, they're quick. You don't have to wait for 100 cycles of azacitidine to see those responses. It's usually 1, sometimes 2, but usually after 1. And it's just plain better. And I think Dan's absolutely right that we were relieved because, first of all, there were a couple of other studies presented at ASH in which the azacitidine arm was looking kind of a lot better than we thought. There were patients hanging out for a year or 11 months of overall survival. And of course, this was a survival study. So that was a little bit worrisome. And then you had the VIALE-C. So yes, the low-dose Ara-C study. And actually, I am the senior author on that paper. Andrew Way is first, and we're putting together an editorial to explain that, because I think it's clinically, I think it's a useful regimen. Those response rates were real. It is absolutely overshadowed by the azacitidine data, but sometimes we really do have patients who've had 10 cycles of a hypomethylating agent before they officially convert to AML, or who are in a situation where you just don't think that another round of HMA is going to work. And the question is, can some of those patients still benefit from the addition of venetoclax to low-dose cytarabine? And I still think there are patients for whom there might be a benefit. And I do think that, much like the phase 3 data that we saw years ago, Tarjan's data on decitabine, which initially did not show a survival benefit, but then with longer follow-up did, I think that those studies are statistically kind of messed up. And the reason that you're not seeing the benefit is more because of disadvantageous study design with respect to hazard ratio and statistics, rather than that the regimen doesn't have any benefit. So AZA and VEN is the new standard of care. There are probably some patients where I would try low-dose Ara-C, venetoclax if you don't want to, if you really don't think more HMA is going to be of benefit. And I do think the rest of the world is scrambling to try to get the regulatory approval so that they can apply these, this really practice-changing regimen for their patients.